Alterations in cardiac output and tissue perfusion. Cardiovascular surgery. Cardiopulmonary bypass, or extracorporeal circulation, is mechanically circulating and oxygenating blood outside of the body while the beating heart is stopped. Disadvantages to the CABG, or cardiopulmonary bypass graft, is a long operative period, anticoagulation, hypotension, a risk for stroke, and dysrhythmias. Indications include the clients that have multiple coronary artery occlusions, atheromas that are calcified and non-compressible, an anatomic location of the occlusion that will interfere with the safe insertion of a coronary artery catheter. The procedure is done by bypassing or detouring around the occluded portion of one or more coronary arteries with a relocated blood vessel. And that graft vessel may be obtained from the saphenous vein in the client's leg. An alternative to the saphenous vein would include the internal mammary vein, the internal thoracic arteries, the basilic vein, the cephalic vein in the arm, the radial artery, and the gastroepiploic artery from the stomach. Surgical techniques include the conventional coronary artery bypass graft, or the CABG, and the procedure attaches the harvested saphenous vein to the aorta below the occlusion. There may be a double CABG, triple, or quadruple CABG. Another technique would be the off-pump coronary artery bypass. There's no use of the cardiopulmonary bypass machine with this procedure. Adenosine or adenocard might be used to help slow the heart rate. The instruments will lift and stabilize the graft vessels on the anterior, lateral, and posterior wall of the beating heart. An advantage to this is a reduced mortality rate, fewer postoperative complications, and decreased postoperative recovery time. Another technique includes the minimally invasive direct coronary artery bypass, in which an endoscopic view of the heart and the grafting vessels are done through a small incision between the ribs. Unfortunately, only one or two vessels can be grafted with this procedure. And then the port access coronary artery bypass. It's also called the TCAB. This uses a cardiopulmonary bypass machine that's attached to the femoral artery and the vein instead of the great vessels of the heart. A triple lumen vascular catheter will be inserted through a thoracoscope with a video camera and transesophageal echocardiography to help visualize that operative area. Another advantage to this is going to be the shortened operative time, reduced mortality rate from complications, and a faster recovery. So a client is recovering from a conventional coronary artery bypass graft, or a CABG procedure. The nurse can expect what? These clients are going to have that 12-inch mid-chest incision, that incision that runs down the sternum. So valve repairs and replacements. Methods of repair are going to include the commissurotomy, which is an opening an adhesion in the valve cusp, and that involves a thoracotomy. A balloon valvuloplasty is a balloon catheter that will help stretch that stenosed valve. A cardiopulmonary bypass. A valvuloplasty, which is actually just repairing the valve itself, and an annuloplasty, which is a repair of the fibrous ring that encircles the valve. Valve replacement types include a mechanical valve and a bioprosthetic valve. Advantages would include less surgical trauma, decreased blood loss, faster mobility, less mechanical ventilation, and improved cosmetic appearance. The repair of ventricular aneurysms or heart tumors. With the ventricular aneurysm, these are caused by an infarcted area of the myocardium, and it balloons outward and will actually form thrombi or a myocardial infarction. And an emergency procedure will be required to help suture that weakened area so it doesn't rupture. Removal of heart tumors, benign and malignant tumors on the heart are going to be pretty rare. The benign tumors will extend from the pedicle, and they're pretty uncomplicated. But malignant tumors are going to have a pretty poor prognosis. A non-penetrating injury of the chest might result in what we call cardiac tamponade. And remember, that is where the pericardium begins to fill with fluid and compresses the action of the pumping heart. And it can compress it so severely that the heart is no longer able to beat. Causes would include a crushing injury that causes bruising and bleeding. It's going to require bed rest, maybe a pericardiocentesis, or an open thoracotomy to repair this. A penetrating injury would include stab wounds or gunshot wounds. Treatment would include large tears, and that would require surgery, and actually can cause immediate shock due to hemorrhage. Heart transplantation causes might be due to a client having cardiomyopathy, or end-stage coronary artery disease, or end-stage heart failure, and congenital cardiac defects. Transplant problems include rejection, which is hyperacute, acute, or chronic rejections, fever, and flu-like symptoms, shortness of breath, chest pain, weight gain, fatigue, and an elevated blood pressure. These clients will require immunosuppressive drugs. Infection is another complication, and it can be bacterial, viral, or fungal because of that immunosuppressive drugs. Symptoms will be very similar to rejection. These infections can be life-threatening. We treat them with antibiotics, antivirals, or antifungals, depending on what the cause is. There is a pretty high cost. There's the pre-heart transplant evaluation, the surgery, the drugs, the post-surgery care, and follow-up tests that can actually run into millions of dollars. Cardiovascular disease are common problems among heart transplant recipients. They don't experience angina because that heart's nerve supply is no longer intact. A rate of survival is 85 to 90% for 1 year post-surgery, but 10-year survival is 56%. There's also a scarcity of donor organs. 20% of 3,000 people awaiting heart transplants will die before a donor becomes available. Clients awaiting heart transplantation are assigned a status code that corresponds to their medical urgency. The nurse understands that if a client is determined a status 1B, the client must have the following qualifications. And that's going to be D. The client has a left or right implanted ventricular assist device. Vascular grafts bypass or replace diseased sections of the major systemic blood vessels, such as the aorta, femoral, and popliteal arteries. Types include a synthetic fiber, which is made of Dacron or Teflon, or human tissue that's obtained from cadavers. An embolectomy and thrombectomy is the removal of a thrombus or an embolus that occludes a major vessel. We may do a replacement graft, or we may do what's called an endarterectomy. This is a procedure that resects and removes the lining of an artery, or removes atherosclerotic plaques from the aorta, carotid, femoral, or popliteal arteries. These clients are going to require hemodynamic monitoring, so it's necessary to assess the volume and the pressure of the blood in the heart and vascular system, and sometimes this is done with a surgically inserted catheter. We can do it through monitoring of the blood pressure, from a catheter placement in the peripheral artery, often in the radial, brachial, or femoral arteries. We can do a central venous pressure, which will obtain a right atrial pressure. Normal would be 10 to 7 millimeters of mercury. This is often a catheter that's placed through the jugular or subclavian veins. Or we can do pulmonary artery pressure monitoring, which assesses the left ventricular function. It requires a pulmonary capillary wedge pressure and left ventricular end diastolic pressures and a cardiac index. So a client recovering from cardiovascular surgery is going to be at risk for decreased cardiac output related to impaired ventricular contraction. To maintain an adequate cardiac output, nursing interventions are going to include administering prescribed inotropic and antidysrhythmic medications.